welcome everybody. We're right on 7:30. People are going to continue to join us as we start this, but we want to get started today. And of course, we would like to start with Josh giving us an acknowledgement of country. Josh, and by the way, Josh wrote our beautiful acknowledgement of country on our website, and he also wrote our acknowledgement for NAIDOC Week. So Josh, would you please start us with an acknowledgement of country?
Yeah, thank you, Linda. Being that we're all on Zoom and it sounds like there's people from all over the place at the moment, there's going to be people on lots of different countries, but as always, we need to begin by acknowledging the traditional owners of the beautiful lands where we're meeting on today. I'm talking to you from a Wiradjuri country tonight, and I acknowledge them as the traditional owners of the land I'm on. But We Are Hughes pays respects to all Indigenous elders past, present and future, and we extend those respects to and welcome any Indigenous persons that are joining us here tonight. Thank you.
Thank you very much, Josh. Right, thank you everybody for joining us. And if you're just being admitted, everybody's been admitted as we go. We have 68 people joining us here this evening, which is great because, as you know, this was a very short, sharp meeting because, as you can appreciate, it's not easy getting 3 medical professionals together. Possibly a bit easier as we're operating over Zooms, but I am incredibly grateful for these 3 medical professionals sharing their time with us this evening. What we are doing tonight as We Are Hughes is without being too cheesy, we are being the change we want to see. When we elect our member, and we will, when we have our fabulous independent representing Hughes, part of what we expect to see as an electorate and part of this community that will endorse someone is we would like them to include us. But importantly, one of our 3 tenets is being informed. Part of being informed, we would like our endorsed member or our ultimate elected member to include us and give us access to experts, for want of a better word, or people who are knowledgeable in their field. And this is what we're doing tonight. We're sitting here in the middle of a pandemic. It's unknown territory for most of us, and we all participate in this pandemic in our own ways, and we wear many hats. We're mothers, we're daughters, we're children. But we also have our professional lives. And tonight we are welcoming these 3 professionals to share with us their journey. So without further ado, I would like to introduce Professor Kerryn Phelps. Kerryn needs little introduction. And guess what? I haven't got Kerryn's bio in front of me, but I feel like I know Kerryn well enough that I can share a few things with you. Kerryn is a health communicator. Her world has been about communicating health literacy. Of course, Kerryn was recently the federal member for Wentworth. She has been president of both the state AMA and federal Australian Medical Association, so she knows what it's like to operate at a state and federal capacity. Kerryn wears many hats. This evening, Kerryn is going to share with us graciously her journey through this pandemic. So, Kerryn, first of all, can you tell us a little bit about where you are zooming in from? And in the spirit of census, which we're all going to fill out tonight, and you all have about an extra 70 people sitting in your lounge room, Kerryn, can you tell us where you're zooming in from and how many other people are in the dwelling with you?
Well, hello, Linda, and hello, everybody. And I'd like to acknowledge the traditional owners of the land from which I'm speaking today, which is Dharawal country. And for those of you in Hughes, you'll recognise that that is on the eastern edge of Hughes in Bundeena. And Bundeena, of course, is an Aboriginal name, and it means noise like thunder, which some people say is because of the sound of the waves crashing on the beach. But I think looking forward, it may well be the noise that We Are Hughes will be making between now and the next election.
That's great, yeah. something I love is seeing those photos of celebrations when yourself, when Zali, when Helen Haynes and Kathy McGowan won their elections, and there's just swarms of people wearing a massive colour cheering. So I actually often think about the after party on election night. So anyway, so Kerryn, I'd like you to take your mind back to the beginning of the pandemic. We just moved out of bushfires. We were already on the eastern seaboard of Australia. We're all pretty traumatised. Tell us what it was like for you as a GP, moving from that and hearing this word pandemic, which was officially a pandemic in March. How did you react?
Well, Linda, I can remember the 19-20 bushfire season. It was a catastrophic time for people really across the state, particularly people with respiratory problems. It was a horrendous time, people really suffering very badly from respiratory problems. And I found myself during that time trying to provide over social media health messages for people in how to try to protect themselves, protect their breathing, protect their children from the effects of bushfire smoke. And obviously it wasn't just about the bushfire smoke that was affecting people. It was the terrible situation of people losing their homes, losing their lives, losing, in many cases, everything they had. Our bushfire volunteers were working tirelessly to try and get those bushfires under control. And I think it was one of those times where Australians pulled together, and we could see the number of people who volunteered, worked together and did whatever they could to help their neighbours and to really bring about as much support as they could for people who had suffered so badly through those catastrophic bushfires. And it was on the back of that, around about, I think it was about New Year's Eve, around the 31st of December in 2019, we started to hear these first reports about this novel coronavirus coming from Wuhan in China. And I had an uneasy feeling when I first heard about it. And as we went through that earlier part of January and towards the latter part of January, and we were hearing a lot of misinformation, things like, this was not a respiratory pathogen. We were hearing that this was something that was spread by people eating bats. And yet the pattern of distribution of this virus and the pattern of spread that we could see, there are not that many people eat bats, I have to tell you. So there had to be a different sort of spread, and being a respiratory illness in the main, although of course we now know a lot more about this virus and how it can affect pretty much every system in the body, from the neurological system to the heart to the lungs and to other parts of the body. But in those early stages when we were hearing about this virus, it was very clear that this was human to human spread. And so I could see that there was misinformation already coming out of even quite significant organisations, and a lot of confusion. Towards the end of January, I think it was, we got a name for this virus. It started to be called COVID-19. And it was a novel coronavirus, and it was given a name and a number. And we then started in Australia to be getting messages from our own health department and politicians saying, if you're coming back from overseas and you think you might have this virus and you're feeling unwell, go to your GP. Now, I'm sitting in general practice and I'm looking at television reports of what was happening in Wuhan, and the people who are working in healthcare with COVID patients in Wuhan who were literally wearing spacesuits to try and protect them from getting the virus. We were hearing about reports of healthcare workers who are coming down with this virus and dying from it. And I'm thinking, why are you sending people to unprotected general practices when what we should be doing is having some form of triaging system, some way of having people tested before they go to general practice, managed in a situation where the healthcare workers are protected. And so one of the first pieces of advice that I thought that I needed to get out there was, please don't come to your general practice if you have any respiratory symptoms. And then the health departments started to set up specialised clinics to deal with people. In those early days, when people were wanting to be tested, it was taking a week to get an appointment. I mean, these days we've got these drive-through clinics, which took some time to set up, and I'll talk a little bit more about that. But in the early days of this, people were taking a week to get an appointment and then 4 or 5 days for a result to come back. And so we had people who were potentially infectious and actually infectious in the community, who were finding it very difficult to even get tested. Our own doctors were doing drive-throughs, picking up swabs if they had a sore throat or a runny nose or a cough. They were picking up swabs. Somebody would pass it through the window. They'd swab themselves, pop it back into the bag, and a gloved person would take that and make sure that it was safely sent to pathology. And so, you know, we thought, well, what can we do about this? And then one of our clinics set up a drive-by testing clinic so that we had a doctor who was in PPE who could do one of these drive-by tests. And we just set that up in one of the laneways nearby to the surgery. And then other general practices started doing that as well. And then, of course, we had health services that started to pick up that as well, and started to do those drive-by tests, and the pathology companies were able to then get more of the reagents that they needed in order to do the test, so that it took less time, so people were not in the community or isolated for any longer than needed to happen. So it's hard to kind of cast your mind back to how things were then. And I remember around the middle of last year, speaking on, and of course with my background in health communication over more than 35 years, I thought it's really important that we have some trusted voices out there, that people can ask their questions, that we can sort of clear up some of the misinformation that was going out there about COVID-19 at the time, encourage people to be tested, encourage people to isolate, and understand more about what this virus is about. And even it was only just about a year ago, we were saying, you know, if only we had a vaccine that would work to reduce the infectivity of this virus, to reduce its impact on people. And of course, quite quickly, remarkably quickly, our medical scientists around the world were actually able to perform a medical miracle, which was to come up with a range of vaccines to have an impact on the outcome for people who came in contact with this virus or actually had this virus. And the vaccination program has been rolling out at various paces around the world. And it's really been quite remarkable to see that happening. So I think that's a little bit of a general journey through the earlier part of this pandemic from a GP's perspective.
Okay. I want to ask you, Kerryn, I've been privy, I sat with all these 3 doctors for a long time, and they had to basically hang up their phones or pretend that the computers didn't work anymore to get me off, because their stories are fascinating. But I wouldn't mind if you shared with us, Kerryn, how you became a health communicator, because health literacy is so fundamentally important in this environment that we all find ourselves. We're getting information from all over the place, and I believe that you're also getting information at the same time as we are sometimes. But could you just share, I find this fascinating, about how you first became a health communicator?
Well, it's interesting, Linda. I had a baby in the middle of my intern year, and as part of my internship, I was allocated to a peripheral hospital up on the Northern Beaches in Sydney. And part of my job at that stage, part of the job of residents and registrars, was to help to educate the nurses who were working in the hospitals, because at that stage they weren't going to university to train. And so as part of that job, what I was doing was to look at health information and to make it understandable to young men and women who are coming out of school, going into nursing, and who didn't have any background in health or might have had very variable levels of health literacy. And I became very interested in the education side to people who were interested, obviously as health professionals, but who were very fresh to the healthcare professions. And so I found that interesting. And of course, having had a baby in my early 20s, I was very interested in anything that had to do with baby and child health, and among other things, of course, going to general practice very young as well. And so there was at that time an anti-vax movement, very long time ago now. It seems to have been around ever since vaccines have been around, I think. And I thought, you know, what young parents actually need is reassurance through information. And so I thought I'll write a story for a women's magazine, and I thought, well, I'll write it for the Women's Weekly. Isn't that what you do? And I contacted the editor of the Women's Weekly and said, look, I'm a young mum, I'm a doctor, I've written this article about how important childhood vaccination is and countering some of the arguments about the anti-vaxxers. And the editor of the Women's Weekly at the time said, oh, that's terrific, show us, you know, your work. And of course, in those days, we didn't have computers where we could email things. You had to actually type things up, and it was in hard copy. So I went in and I delivered to the editor, and she had a look at it and she said, that's great, we'll publish that. And I thought, wow, that was great. And then I contacted Channel 10 at the time, Good Morning Australia, and I thought, we need to get this message out far and wide. So when the article was published, I contacted the producers at the Good Morning Australia program on 10. And they said, yeah, sure, come in and talk about it. So I came in to talk about vaccination, why it was so important. And before I'd left the studio, the executive producer came down and he said, you know, we'd really like to have a doctor to come regularly on the show and talk about, you know, health issues, pretty much anything you'd like to talk about, something that's in the news. And so I said, that sounds great, be happy to do that. And then shortly after, and I think I've told you this story, Linda, I was asked to start doing stories out on the road. So I pulled together what we call talent, which is people who can tell a story, a location, found a story that was really important to talk about. In this particular case, it was about children swallowing those little button batteries and how dangerous that can be, and lined it up with the Children's Hospital, which was a bit more difficult than organising a royal visit because it was so complicated to get camera crews in at that stage. And then I was taught how to shotlist and edit. And then after that particular story, they said, well, you can go out and, you know, with the help of the camera crew and the editor, you can produce stories on a regular basis. So that's kind of how I got into television, and then later on radio, and then a regular column with the Women's Weekly, Daily Telegraph. So I've done a lot of work in health communication across all of those mainstream media platforms. Of course, social media is very important these days. And I continue to do that work wherever I think it's going to be helpful. And certainly the last 18 months has been very much a case of staying on top of the information about COVID-19, making sure the information that's going out, confusing as it can be, coming from some sources, is as easy as people can understand it, so that anybody who has questions about COVID-19, that they have somebody with a lot of experience, not only in health communication, but in general practice, to be able to, and in medical politics, of course, to be able to put all those elements together and explain to people what's going on, what they need to do, why it's important.
Right, thank you. And the rest is history. So I just found it extraordinary that the first article you wrote was on vaccines, and, you know, here you are today, and here we are today, many years later, and vaccines are still central. You can see why I would like to speak with these great doctors for a lot longer than 20 minutes, but I realise now I'm looking at it, we have 5 minutes, and this evening is going to fly. I would really like to speak with you about what happened when you put in your expression of interest. Now, you were on the drum the other night and you said something about 8 vials of vaccine. I thought, what does that mean? And then you explained to me how the whole expression of interest for becoming a doctor, a GP surgery under the federal system, what you went through in order to be able to facilitate that vaccine rollout. Can you explain how that worked? And, you know, in 5 minutes or less, Kerryn.
I'll do my best, Linda. Well, general practices are the vaccine hubs for the nation. More than half of the vaccines that have been delivered in Australia have been delivered by GPs during this COVID pandemic. We are used to giving immunisations, but what we do is we have 1 vial, 1 patient, 1 vaccine. And so let's say, for example, a patient comes in, they want to have a flu shot, or they come in for some other reason. We say, look, it's flu season. Did you want to have your flu shot while you're here? We can just go to the vaccine fridge, get the flu shot, that one patient, give them the vaccine, and off you go. So we have that opportunity, what we call opportunistic vaccination, to keep people up to date with their vaccines, because we keep supplies of those vaccines in the vaccine fridge. Now, when there were expressions of interest for the AstraZeneca vaccine for general practice, it was a very different situation, because here was a vaccine that GPs hadn't seen before. It was a vaccine where we needed to account for the possibility of allergy. So we had to keep people, after they'd had the vaccine, for 15 to 30 minutes afterwards to monitor them for any reactions. The vials came with 8 to 10 doses per vial. So we had to book people in batches of 8 to 10 because we were asked not to waste any. So we had to monitor how much of each vial that we were using, whether there was any wastage. And then we had to book people in batches so that, if we opened a vial, that within a particular period of time, we were able to provide people with that vaccine. Because it was a different vaccine than we'd been accustomed to and a different mode of delivery, GPs also had to do quite a lengthy training process online before we could actually start to do the vaccinations. And we also had an administration challenge, because apart from anything else, the GPs who had been successful with their expressions of interest were put up on a website on the Monday, and it wasn't until the Thursday that we were told that we were going to get the vaccine the next day. So we had this period from the Monday through to the Thursday with people ringing up saying, we want the vaccine, we want the vaccine. And we had our administration reception staff trying to take down the names of people saying, we don't know when we're going to get the vaccine. So there was a lot of confusion, there was a lot of upheaval, a lot of disruption. And also through all of this, GPs are having to look after all of our regular caseload of people with acute and chronic diseases who come along to general practices for care and attention for their general practice needs. And we were trying to fit in on top of this extra sessions by doctors who otherwise would have been seeing patients with their usual caseload. So it was an enormous disruption, and most GPs that I know who took this on were doing it as a community service, because we saw how important it was to the community that as many people were vaccinated as possible in the quickest possible time, and that general practice was set up to be able to do that.
Yeah, it's amazing. And I recall you said to me you had 2 practices. One of the, and for no obvious reason, one of your practices was given 400 vials a week and the other was given 50. And there didn't seem to be any logic to that. It was just the way it was. And you also mentioned that you were part of your expression of interest meant you had to take anybody on who wanted a vaccination. So that's on top of your already, I'm assuming, probably full caseload, full patient list. That was my dad squeaking in the background. Right, so Kerryn, I knew this would fly. And you can imagine that I want you all to know that we have a chance to have questions at the end. So write some questions in the chat, and when we come to the end of our 3 wonderful speakers, we will ask some of those questions back. And if you're feeling brave, we'll spotlight you, and you can ask your question on camera, or we can ask the written question. Right. One of the questions I had, and this can be a really short answer for you, Kerryn, and I mentioned this before, we're learning about things on the fly, that the situation is changing, that we personally are going through our own risk-benefit analysis, as are you, as our medical professionals. And I asked you, I said, so, we're getting this information from these presses. Are you getting it before us? Are you prepared? And your answer was pretty quick, I remember. Yeah, that was it. That's the one. That laughing one. Yeah, it was a familiar answer.
I wish. No, we don't get too much of a heads up. Well, over the past year and a half, we haven't had much of a heads up with a lot of the information that's coming out. But you have to understand that I think too that our health departments have got they're running as fast as they can, trying to manage a crisis situation. But I think it's really important as we go forward that that doctors are at least warned about the things that are going to impact sort of quite heavily on our practices. Yeah. I think that's really important. And I think it's very important for our patients also that GPs are particularly the GPs are very well informed about as much as possible, because patients keep being told by the politicians to go and talk to your GP about things. So we have to be on top of that information, and so we have to be watching the information coming from ATAGI. We have to be watching the bulletins coming through from the College of GPs. We have to be looking at the media to see what's happening in the political scene, because that information is changing a lot, and it's changing all the time. So we're doing our best to stay up with everything that is being said and all of the information that we need to have, so that our patients are able to make responsible risk-benefit analyses for themselves about which vaccine they are eligible for, what is available, what the potential side effects of each one are. And of course, as that information emerges, we have to incorporate that into our informed consent to people who are having the vaccinations.
Yeah. Thank you so much. And I do wish we had the full hour and a half with each of you. But remember, put your questions together into the chat, and people are looking at them and taking them down. One last question for you, Kerryn. Any parting comment? And this is partly, we're now handing over to Dr. Kim Liu, who I believe you know. Would you like to just parting comment and mention how you know Kim?
Well, I'm delighted to be sharing a panel tonight with Dr. Kim Liu. Kim campaigned alongside me as part of the Doctors for Environment in the Wentworth campaigns, at the by-election campaign and at the federal election campaign. And we have also met each other at the climate rallies. And Kim is a passionate advocate for a healthy environment. And as one of the leaders of the Doctors for the Environment movement, I was also absolutely delighted to see that Kim was recently elected to the Council of the AMA in New South Wales, the state AMA body, and I'm sure she'll have an enormous influence there. And I guess to go full circle here, when I was AMA president back in 2000 to 2003, I ushered in the AMA's first ever policy position statement on climate change and human health. And given that today is the day of the report being released from the IPCC, the latest report, which I'm sure Kim will have more to say about, I'm, as I said, delighted to be sharing this forum with you, Kim. Hi.
Thank you. Just give a wave of appreciation for Kerryn. Thank you. Thanks, Kerryn. Right, now it is now my pleasure, if I can get my screen to work, to introduce to you Dr. Kim Liu. I first bumped shoulders with Dr. Liu down in Canberra at the Rally for Women, which of course the name escapes me right now, but we met in a bar. Kim, you don't mind me calling you Kim,
No.
do you? So, you know, all these lovely connections. So, but I'm going to have to read off the screen, Kim. So Kim is, she's a mother of two, and she's very active in the climate change movement. Both her children are involved with Youth for Climate Change. She's a GP at the Riverstone Family Medical Practice, which was Practice of the Year in 2014. She is currently the New South Wales Chair of the Doctors for the Environment Australia, and she is on the Council of the New South Wales AMA. She wears many hats. Tonight we are speaking with her as a GP, and I'm sure she will change hats and speak with us from all of those voices that she has within. Welcome, Dr. Kim Liu.
Oh, thank you. So I live and work in the land of the Darug Nation and also the Hillsong Church. And my children are now turning 21 and 16, and I've been working in Western Sydney for 32 years now. And in Western Sydney is 6 to 8 degrees hotter than the rest of Sydney. A lot of the houses around the practice are built on flood zone. We've got green areas being filled with unsustainable housing. And so the impacts of climate change have been, my patients have been on the front line. During the 2019-20 smoke and heat, we had, with the Western Sydney, we had temperatures up to 48.9 and at 37 days over 35 degrees. And it was just terrible for my patients. And this is part of the reason I'm so active in the climate movement.
So I'm going to give you a similar question to Kerryn. I want you to take your mind back to the beginning of the pandemic as well. Of course, this was a time which we seem to forget, but in the beginning of the pandemic, we were concerned with things like how long was the virus going to last on stainless steel compared to on my milk bottle. That feels like a lifetime ago, but that's where our minds were at. At the beginning of this pandemic, we were concerned about surfaces. We were washing things, and we were versed in how long viruses lasted on surfaces. Can you take your mind back to that time? How was it for you, not necessarily about surfaces, as a GP, hearing this word pandemic?
So, like watching what was happening in China, then the death of the ophthalmologist who sounded the concern about the unusual pneumonias was scary. Like a doctor who actually understood that there was a respiratory virus going around dying from it in China. And our practice also saw that this could have was possibly going to be a big problem within general practice. In the end, what our practice did in the middle of last year is that we organised a COVID drive-through clinic in the car park across the road in the pools across the road. So we had to staff that. I should say, Riverstone General Family Practice, we've got 16 doctors and about 8 nurses, and we have a lot of auxiliary staff, and we have 3 medical students at any time. So part of the reason we could run a respiratory clinic in our car park, fully PPE'd, seeing respiratory patients, and run a COVID drive-through clinic is because we had a lot of capacity in terms of our staff. And so in terms of what we do now is we also run our vaccine clinics, and on a Tuesday and a Thursday, where we immunise 200 people on each of those 2 days with a Pfizer and AstraZeneca. And so I think with COVID, what everyone failed to appreciate, including the Department of Health, was that it's a respiratory virus that's respiratory spread. And so we can now see why there are breaches in hotel quarantine, and why when people were looking for evidence of people being in contact with each other, it was actually air pollution. It's air pollution from the people who breathe the virus out. And when the virus hangs in the air, and if someone walks past it, even a few minutes later, you breathe in the virus. So our whole health system, and this is including our own departments of health, failed to see that it wasn't really droplet spread on surfaces, although it's really important to wipe all the surfaces down. It's that you breathe out the virus, and then other people breathe it in. And it's tiny. It's like the microparticulate matter I talk about with air pollution. And that's what's so frightening about the current outbreak of Delta, because one person can spread it to 5 to 8 people. And really, part of the population is complacent about it and don't understand how exceedingly catchy it is. Yeah. And even with clear messaging has been done through the health department. And so because when you know something is respiratory spread, you know that masks are important, you know that ventilation is really important. And a lot of the spread at the moment is people don't appreciate that you need good ventilation to reduce the number of people catching this virus.
Yeah, I found that that comparison with particulate matter for pollution, we know when the air is polluted. Yeah. And you explained to me that these were 2.5, and yet the virus was 4.
Yeah, so it's, I mean, they're more like liquid. Yeah, so because I explain to patients sometimes, like when you stand behind a diesel bus, you can see the air pollution, you smell the diesel, and it hangs around for a while. Kind of think about COVID as that. But you can't see it and you can't smell it. It's kind of like CO2, isn't it? Can't see it and you can't smell it, but it's going to be there.
Yeah. And
just imagine, I get my patients to imagine if someone breathes, just imagine that around them is their breath. So that, you know, like wear a mask when you're walking. Like if you're doing a light jog, wear a mask. But because there's so many, like even around here, because I do about 24 kilometers a week around, and people just aren't wearing masks and they're still talking to each other close by. The messaging needs to be clearer for our community.
Yeah, I wanted to ask you about that. So when your clients are coming in now, I mean, we're not America. We don't choose, nobody advertises our medications to us like they do in America, but suddenly we're all conversant with different types of vaccines. But we're not going to talk about that today. But I am interested in what you have done for your clients when they come in. You've given them the ability to go and get a blood test. You've taken away some fear. And I'm not explaining this well, but can you please explain this? What you've done to relax your patients?
So the problem is the messaging regarding the AstraZeneca vaccine was that the clotting was the reason why a lot of people wouldn't have it. But the risk of clotting is tiny. It's absolutely tiny. So if you look at someone who's in their 30s, it's about 1.6 out of 100,000 people. And we know how to detect the clots early, so that they're completely treatable in Australia. So we know that if TTS occurs, which one of the particles in the blood called the platelets that help you clot goes down, and a clotting factor called D-dimer goes up. So I tell my patients that if you get a headache, chest pain, abdominal pain, leg pain, anything that's unusual after day 4, get the blood test done. And so we've also organised with Douglas Hanly Moir, which is our local pathology, that if a patient comes in with a form saying AZ vaccine, exclude TTS, then the blood test that gets done, Douglas Hanly Moir rings us to tell us the results, and I communicate that to the patients. So the patients have a degree of autonomy and feel kind of safe that there is a pathway if they get a clot, that they're going to be treated early. So every single patient of mine who gets an AZ vaccine, we do a consent and they get a blood test form. And then we run the clinics. So at the moment, we're running respiratory clinics with a 2-story practice, and we run the COVID clinic actually at the moment outside in a car park in a tent, so that we can socially distance chairs and have free airflow because it's in the car park.
Yep.
And on the days that we're not running the COVID clinic, we run the respiratory clinic. So any of our patients who actually have a COVID negative test but still have a persistent respiratory or any other illness get seen in the tent as well, so that we still provide care for sick patients. Because what's happened, especially around Western Sydney, where we have got a lot of solo practices, they haven't been able to run. We're lucky that our practice was built from ground up to be for a pandemic, actually, because we've got 8 rooms for doctors and there's 2 windows in each room so we can ventilate. We've got a big treatment room where you can actually open all the windows which sit up top. And we have a downstairs room that we still do the flu vaccines in. So that's separate from the COVID vaccine clinic. And so we've been able to run all these clinics with all our doctors and nurses and our medical students. So we've been able to provide care for our patients, because one of the things that's happened during COVID is a lot of people with chronic diseases just didn't see their doctors because they were frightened of coming in and being exposed. But part of our within the community of our practice is that our patients, we're on Facebook and we're on Instagram. And so actually at the beginning of the vaccines rollout, all our patients were texted saying we would contact them when the vaccines arrive, and to follow us on Facebook and Instagram. So we actually communicate with a lot of patients on Facebook and Instagram, so they know what's available. And we also put training on how to wear a mask. We've actually gone through how the clinic, we've done a YouTube video to show them how the practice is running, the different parts of the practice, to show our patients it's safe to come in for your normal checks. Like if you have kids who need to be immunized, or our chronic patients with heart failure, renal failure, they're still safe to come upstairs to the practice because no one sick comes upstairs.
Yeah, I can see architecturally some new new code coming in. So
yeah, so even when we're running all these clinics, we're divided into red, blue, and green team, so that we rotated through teams. So if one team, this is before the vaccine, so that if one team was infected, we didn't infect the whole practice. So we ran like a mini hospital.
You talked about the mental health of your patients as well. I mean, we know, through science and compliance, we'll eventually get out of this, but it's this eventual bit that we're sitting in the middle that there is so much suffering, isn't there?
Oh, it's difficult for my patients because I run sort of my patients I've got homeless patients. We've actually got one patient who sleeps in the park, to my really wealthy patients. And I have a lot of patients who live on their own with very little family around and not much with social, who don't have the social cohesion within their community. And they've been significantly impacted by the COVID crisis because they haven't been able to go to the park, to go to the shops, to walk to the shops. And I've got a large cohort of elderly patients who are used to going to bingo, used to going to bowls, used to going have a drink at the pub, having morning and afternoon tea, who now can't do that. So it's been really difficult. And when you're in a certain age group, you kind of don't Zoom with your friends for afternoon tea. So in a way, with some of my patients, the only social contact they have is with us when they come in for their routine check.
Yeah.
So, because during non-COVID times, we try to connect our patients with the local community, the community centre, the men's shed. We had peer support workers who'd visit them. But during this moment of time, a lot of those things that help our patients function within community just can't be continued.
Yeah. You sound like you've got an extraordinary practice. And these are things that you've enacted yourself as a GP, aren't they? So kudos to you, and you're probably going to have a huge patient list after this presentation this evening. Now, look, I know you also gave a presentation for a friend who had a veterinary clinic, and some of her staff were hesitant. We might leave that part, if you can tell a little bit about that story at the end in question time, because I'm sure people will be very interested about that. You also mentioned a lack of hydroxychloroquine for patients who had, which of course is topical from our guy in Hughes, has an obsession with hydroxychloroquine, patients who couldn't access it for rheumatoid arthritis and other inflammatory conditions. I mean, there is so much that you have to tell us. But our last part, because we are going to, you can tell how long we can speak with each of these doctors. You recently wrote an article that was in your community paper. The headline of this paper was Pleas from a GP about COVID. And one line of it is, as a doctor and knowing how infectious the Delta COVID strain is, I'm worried about the community and the potential burden on an already stressed health sector. This is a perfect segue to our next speaker, but I would like to ask you, as somebody that sits on the AMA Council, is this something that is really troublesome to you, the burdening of our health system?
Yes, I mean, even if you look at in intensive care, because I was speaking to one of my best friends who's an intensivist, actually in Alice Springs, is that COVID patients stay a long time in ICU. Normally what happens is that most people who go to ICU have had heart surgery, lung surgery, cancer surgery. But if we actually end up having a large number of people in ICU, you delay a lot of surgery for other people, but then you have 1 in 10 people in ICU in Australia dying from COVID. And so it's really, our health system is really burdened at this point in time, and doctors who work in hospital are stressed. Yeah. So if we actually don't actually get
Yeah, thank you. And on that, we're going to hand over. Thank you very much, Kim Lou, Dr. Kim. If everyone could just give Dr. Lou a wave of appreciation, that would be great. Thank you so much. We'll see you at the end in our question time again. But on that note, it's a perfect introduction to Dr. Jennifer Tobin. If anybody attended one of our meetings a long time ago, over a year ago, Jennifer gave a presentation and it literally moved some people to tears. So I'm going to make Jennifer revisit that for us because it's fun to make people cry. So no, Jennifer is a Hughes resident. I became aware of Jennifer's passion through some online comments that she made to Craig Kelly on his Facebook page. I thought, hello, who's this? And I reached out and we started chatting and I found out just how fantastic and how passionate and amazing this emergency doctor is. So I'm going to hand over to Jennifer and I'm going to start with a question, which is here somewhere on my notes. I'm going to ask you, in the spirit of a census, where are you today and how many people are in your dwelling?
Hi everyone. So I would like to start with acknowledging the traditional custodians of the land that I'm on, the Darawal people. I'm currently living in Menai and I'm here with my partner and my almost 2-year-old baby. But I am, as you can probably tell from the accent, originally from the UK and I moved over here in 2011, meaning to stay for a year. Absolutely loved it, loved the people and become an Australian citizen and haven't looked back since.
Thank you, Jennifer. Now I'm going to take you back to early COVID days as well, when we found out that movie stars and politicians also weren't immune, when we had Tom Hanks and Peter Dutton were some of our first patients. Take us back to that time and can you relay part of that story that you told us a long time ago, how it impacted you immediately?
So being an emergency frontline worker, so at that time I was working in a more tertiary emergency that's different from my role at the moment in a rural setting. And none of us, like Kerryn, Professor Phelps and Dr. Lou have said, we're getting information on the ground running. And so none of us really knew. We were seeing images from Italy, you know, from the European wave that happened. And me and my partner had to sit down and say, right, at this point, there's a shortage of PPE. Our hospitals are under-resourced. This sounds like it's really infectious. You are probably going to get infected. Like you are probably going to get COVID. And so we were working on the assumption that, you know, dealing with respiratory patients, what would that mean? I had a 4-month-old baby. Does that mean I go away to a hotel for like 6 months or whatever whilst the pandemic's raging? We had conversations about whether I would have to do like 24-hour shifts. Is it going to be crazy keeping food in the car? We had conversations about where would I get changed? So where would my contaminated clothes go? You know, so there's a point where I was really worried, working in a tertiary hospital and seeing respiratory patients. So I'd sort of get changed in the garage and then like have a shower and then get into bed. And that was probably only 2 or 3 weeks before we realized, actually, hang on, Australia's handled this pretty well. That's not going to be my life. But it was a reality for a few of my doctor friends in the UK working in ICU and emergency. And that was their life, sort of 24-hour shifts, 7 days a week almost, especially my friends that are emergency consultants. And the whole getting changed and all of that stuff. So that was a frightening discussion to have with my partner about a reality that we're lucky didn't eventuate.
Yeah. So we've come a long way, strangely. Like, I mean, this is part of why I was asking these original questions, mentioning stainless steel, Peter Dutton, Tom Hanks. These are things that when you hear them, you go, oh, that's right. But this is when we've come so far. So I asked you when we first got on the phone, I said to you, so Jennifer, what are you doing now? Are you working, because I knew you worked in 2 hospitals, and you said, oh, well, I had to go through a risk, benefit analysis, and I'm now working 1 week at the hospital in Nelson's Bay. And I said, oh, okay, and 3 weeks down here. And you said, no, out of this risk benefit analysis. And I thought it was a protection thing for your family, but not so. Can you explain what that 1 week on, 3 week off is really about, the impact that it can have on the hospital that you're in?
So I'll give you a bit of background on Tomaree Community Hospital, which is a lovely hospital in Nelson's Bay in Port Stephens. It's got a 14-bed inpatient ward that's attached to a little like emergency triage room. There is a medical practice as well that's a bit separate, and then a 4-bed emergency department with a resus room, 2 beds and isolation room. It's staffed by 1 doctor for a day shift, 1 doctor for a night shift, and about 4 nurses per shift, between 4 to 6 nurses. We occasionally get an extra doctor in school holidays. So it's pretty small. We have 1 radiographer and an X-ray department, yay, with 1 X-ray machine, and we just got a CT scanner Monday to Friday. Very exciting. And I realized I'm a big integral part of there. I'm actually doing the clinical lead role up there, because they're not part of hospitals, they're part of community health, and they struggle a little bit sometimes with like the emergency side of things. So I'm doing a clinical lead role up there, and I realized, hey, I'm a little bit important up there, and if I can't go to work for a week because I've been a close contact or been exposed, that hospital will not have a doctor for that week. They've only got 2 doctors that live in the area that can assist last minute, and everyone else is sort of like fly in, fly out. So I'm doing I do 5 days on, then a week off, and then like 5 to 6 days on. And obviously I'm getting my weekly COVID tests. And when I'm up there, I'm not going anywhere, and I'm down here, I'm not going anywhere. But it's sort of to still allow me to work and provide a service up there, because otherwise that hospital would be very underrun. Yeah.
What struck me in the conversation with you is how tightly wound this is, how it's so very tenuous, and the testing of patients when they come in, and the way they have to be tested before they get there. You told me one story about a lady with a sore ankle, for example. Are you able to share that story? Yeah. Is that okay?
We're finding it really hard it was really interesting to hear, Dr. Lou, about the capacity that you have in the larger GP centres in the city. And I think this is a real juxtaposition of what is happening in some rural centres, where, so if we have a patient with COVID in Tomaree, that entire hospital pretty much has to close. Like, we have 1 isolation room that's not really a proper isolation room, and we have 1 nurse in emergency. So if we have say a patient that comes in and is waiting on a COVID test and is on BiPAP, they are in the 1 isolation room that we have, and our 1 emergency nurse is with them the whole time and can't come out. So then the triage nurse has to become the emergency nurse. And so it's really hard when you have patients that come in with very, very minor things. The other day we had a lady that came in with just a sore foot, who was a little bit aggressive from the get-go, like, you can't deny me treatment, but she'd had a cough for a couple of days, and she'd had a COVID test that morning and was waiting on the result. And I said, look, your foot seems fine, you can walk on it. Can you not just go home, wait 24 hours? And I'm happy to see you then, but I really can't risk my radiology department, my 1 radiographer, my nurses, because we provide a very important service to the people in Nelson's Bay to save them going to Newcastle a lot of the time. There's not much we can do, but we can do a bit. And there was a lot of anger on her part. You can't deny me treatment, you can't deny me, this so-called virus anyway. And so you can see how this misinformation is spreading into people that are then putting things actually at risk. And the other thing about my small hospital is, and I had a very interesting conversation with some medical GP mums on my Facebook page the other day, and it was very lovely, and we all got on very well, but I was having a hard day because I was at work, I had very sick patients, it's just me, and then the waiting room was full of children between the ages of 6 months to 5 years with fevers, coughs, colds, sore ears, sore throats. A lot of them that have had negative COVID tests, but the GP practices in the area are A, severely underfunded, and B, very, very small, don't have the ventilation, don't have the 2-story system like Dr. Liu has, and they can't afford to see anyone with respiratory. There's already a shortage of GPs in that area anyway, so they have a barn door rule. They don't see anyone with respiratory anyway. Then you've got all these parents with their children with fevers and sore throats that can't get into their GP. And so they all come to emergency. And we had 6 to 9 hour waits for 2-year-olds with a sore ear. And then a lot of people just did not wait, which is, never good. When you have patients did not wait, and we know that outcomes are not as good. You want them to be seen. And it was a completely reasonable thing to want your child to be seen, but it was just me, and I was too busy with another child that was having seizures. And so you can see the knock-on effects of the overwhelming of the hospital system is already starting. Rural North Shore at the moment, and Westmeath and Liverpool, they're probably coping at the moment. I know they won't cope if it spikes, but already rurally, we are not really coping. Like it's been really, really hard. I've got to say, the past couple of months at Tomery.
It's like you're on a knife edge, isn't it?
Yeah.
I've got two more questions for you. One of them is going to bring us full circle back to where we started with Kerryn's first story. But can you share with us what it's like for one person in ICU, the turning story?
Yes. So I'm not exactly sure how much it's happening with the Delta strain now. I haven't had conversations with my ICU colleagues for a while, but I believe it's still happening relatively frequently, is that with COVID lung disease, a benefit is to ventilate sort of part of the day on their back and part of the day with the patient on their front, so proning. Now, if you can imagine a patient in ICU, they have a tube down their throat to help them breathe. They have a nasogastric tube in through their nose or through their mouth to help them feed and to drain their stomach. They have often big lines in their neck. They have lines in their wrist. They have other cannulas in. They have monitoring all over them. And they've got, like, I don't know, between 8 to 20 infusion pumps, depending on what's wrong with them. And you have to turn that patient, knowing that you could lose their airway or their lines at any one point, or lose the drugs that are keeping them asleep. So to prone a patient, from my experience when I was doing ICU, takes between 5 to 8 people, sometimes 10 people if it's a patient with a larger BMI. And it takes about 20 minutes to 45 minutes to fully prone them, and you have to turn these patients 2 to 3 times a day. So if you have just 2 patients in your ICU, you're doing a turn 6 times a day. So you're taking, 6 people each time, and say half an hour each time. So already that's a massive impact on our ICUs.
That's an extraordinary story. That's really opened my eyes to a lot. Now, Jennifer, can you give us your parting story? Can you share with us why you've been so, what's the word I'm after? So concerned that people will become vaccine hesitant, not just for COVID, but this vaccine hesitancy or this anti-vax movement may have its own viral spread across into other preventable communicable diseases.
Unfortunately, is a sad story, and it's from the UK. I was a sort of junior doctor. There was a patient, a young 5-year-old that wasn't vaccinated, and there is a bacteria that is called Haemophilus influenzae that a lot of us will have our vaccines for when we're young, and in rare cases it can sit on the little bit of tissue that covers your food pipe, covers your airway, so when you eat, things don't go down the airway tube, and it can sit on that, and it can swell, and it can become infected with this bacteria, and it can slam shut, and basically you suffocate. And if you don't pick up on it quickly, it gets bad very quickly. And I saw a 5-year-old unfortunately pass away from Haemophilus influenzae epiglottitis that was probably vaccine preventable. And that really hit home to me how important vaccines are. I mean, the parents were, besides themselves. It's awful. And I know that lots of people will have seen babies whooping cough, children with measles, encephalitis. And it's just one of those things that this misinformation about the COVID vaccine, it has a knock-on effect to misinformation about all vaccines. And I think we as healthcare providers and just people that think about others have a duty to really educate on what vaccines are. And I just wanted to end by, I wanted to say this at the start, but I forgot, just how honoured I am to be sharing a stage with Dr. Kim Liu and Professor Kerryn Phelps. Thank you for having me.